On August 7th, 1995, Tyra Hunter, an African American transgender woman, would die by the hands of healthcare providers following a car accident in Washington, D.C. The response to the accident evolved into two failures. One, after the crash, when the first responders arrived, they discovered she was in fact transgender in an attempt to treat her severe bleeding and assess her injuries. Upon this discovery, witnesses reported that the rescuers made derogatory, transphobic, and racist comments and immediately stopped treatment for a reported estimated time of 3 to 7 minutes. Hunter, who was conscious, was left bleeding while rescuers repeatedly laughed, mocked, and ridiculed her. Failure number two. Failure to care for Tyra continued at the DC General Hospital, where the emergency room staff failed to assess her injuries and give her quality standard care, which was later ruled out by legal juries to be malpractice on behalf of the medical team. Bias gave way to the treatment she needed and deserved, and she ended up dying an hour after arriving at the hospital. Tyra's story and the medical failures, as well as the hateful negligence that occurred that night at the scene, should serve as a reminder that cultural humility is not an abstract idea, nor is it an ideal but a crucial and ethical piece in providing healthcare. Tyra's story reflects the systematic problems within the healthcare system that persist today, including discrimination, systemic barriers, stereotyping, and prejudice that many LGBTQ people face. LGBTQ people are individuals whose identity related to sexual orientation, gender identity, or both fall outside of the historical norms of heterosexual and cisgender society. An estimated 30% of LGBTQ population avoid seeking healthcare due to fears of facing prejudice from the healthcare system. This avoidance causes many people to go without the preventative or primary care that they need, which worsens health disparities across a range of conditions. That's a considerate amount of people not receiving healthcare, considering that there are approximately 1.3 million LGBTQ Canadians. LGBTQ Canadians were significantly more likely than their heterosexual counterparts to report having poor to fair mental health, having contemplated suicide in their lifetimes, and experiencing inappropriate behaviors in public, online, and at work. LGBTQ people experience higher rates of mental health challenges, chronic illnesses, and healthcare avoidance, often due to stigma, fear, and discrimination. So, in order to counteract this problem, we have to change our system of healthcare as well as our approach to health, especially when it comes to health assessment. So, where do we start? The healthcare disparities affecting the LGBTQ community are not a mystery. While some come from personal prejudice and biases, they are a manufactured crisis engineered by a medical and nursing education system that systematically fails to prepare healthcare providers for the patient they will inevitably serve. Without adequate training, even the most well-intentioned providers are often not equipped to address the unique healthcare needs the LGBTQ community needs, thus perpetuating cycles of misunderstanding, inadequate care, and mistrust. A comprehensive study of medical schools across the United States and Canada back in 2020 revealed that a median time of only 5 hours is spent on LGBTQ healthcare throughout the entire curriculum. Likewise, 33% of medical schools fail to cover any LGBTQ specific content during students' clinical years. Then, the problem extends deeply to nursing education, where a national survey found that less than one third of nursing faculty reported for a full understanding of the health-related issues affecting the LGBTQ population. A lot of physicians have been named to be LGBTQ competent physicians. However, this label is often just a self-identification without any objective methods to actually verify competency, leaving a lot of patients to navigate a system with no reliable standard of care. So how do we start this problem from the root? Well, 1. We can start mandating comprehensive LGBTQ health curriculum and integrate LGBTQ health topics throughout the entire curriculum of medical and nursing programs. 2. Invest in faculty development and training, where institutions must start providing resources and training for faculty to ensure that they possess the knowledge and skill to teach LGBTQ health topics effectively. And 3. Establish national standards for competency and adopt a cultural humility framework where national accrediting bodies should develop and enforce standards of LGBTQ plus health education to ensure consistency and quality across all programs. One key framework that should be enforced when providing LGBTQ people, or any minorities for that matter, with quality healthcare is the cultural humility framework. Cultural humility is an alternative approach to providing sensitive and high quality patient care, contrasting sharply with the traditional concepts of cultural competency. Instead of focusing on mastering fixed knowledge about patients' culture, cultural humility emphasizes ongoing self-reflection and continuous process of understanding yourself, your biases, and the power dynamics in your relationships. Now that we have and are getting the proper knowledge that we need to give comprehensive care to LGBTQ people, what can competent care look like in practice, especially for health assessments? First, let's look at our physical setting. We need visible signs of acceptance and inclusivity. Healthcare settings that display equality signs and utilize gender neutral language are perceived as safer. When patients see signs that signal equality or any other universal symbols of acceptance, they feel more trust towards the settings and safer to disclose any information. Now let's address facility accommodations, especially the bathrooms. This is just a really crucial and vulnerable area, especially for transgender patients who take great risks for going into public restrooms. So, is it possible for the facility to have individual stalls? Are there any gender neutral washroom? Language and communication signals inclusivity immediately. This can be written or verbal. In regards to inclusive language on forms, patients look for terms like significant others or domestic partner, and they overall just look for any gender neutral language that hints for inclusivity. Now, verbal communication. With this, when you are talking to your patient face to face, it's best to have a patient led communication. The best thing to do is to let the patient take the lead in terminology. For example, some patients may not like the term queer, while others accept it fully. Should also be asking what the patient's preferred pronouns are. This can be on our document, or you can just ask the patient as well. This can change from visit to visit, so it's also really important to take the patient's lead on this one. So now that we know the basics for an inclusive and cultural humility practice in health assessment, what can this look like as a whole? So let's go through the entire process. Step 1. Before the assessment even, you are building safety and trust with your patient. The goal of this phase is to establish a safe environment where the patient feels comfortable disclosing any necessary health information, so you introduce yourself and establish respect. You begin by stating your name and your pronouns and asking for the patient's name and pronouns back. By asking what their pronoun is, it acknowledges that this is a safe space for any gender or sexual identity and expression. Ask for the name that they go by and confirm it matches their chart before documenting or calling them publicly. Now explain the purpose and the process. Describe what a full assessment involves and why it's done. Explaining the process and saying that they can stop you at any time helps establish control for the patient. Now, gain informed consent. This is the consent after you've given them your patient education. Obtain their verbal consent before starting anything or before touching them or their body parts. And if a patient refuses a step, document that respectfully and offer alternatives. Do not make any assumptions about the patient's behavior or needs, as this can lead to incomplete assessment and inadequate care. Now create a safe environment for them. Ensure that privacy is given where you are closing curtains, you are closing doors, and offer a chaperone or some same-gendered nurse if it increases their comfort. Now, during the assessment, on top of cultural humility, you should also apply trauma-informed care. What can this look like? You are always asking before you are touching. You are always explaining what you're about to do, and you avoid making assumptions. During this process, you should also be body positive, where you are avoiding to make comments about body shapes, scars, surgical marks, or hormone effects. Be aware of the socio-political context that shapes the definitions of self and body. LGBTQ individuals, particularly those who have undergone bodily modifications or live with conditions like cancer, may struggle with feeling of not being whole or being abnormal due to society's emphasis on the normal body. Comments about a person's body shape or identity reinforces systems of power and oppression that marginalizes queer bodies. Validate discomfort. By saying it's okay if this feels uncomfortable, you are in control of the pace. Validating patients' discomfort and giving them control of the pace aligns with the core tenets of person-centered care and empathy. Now, practicing inclusive care requires a lot of holistic health assessment. We must assess not just physical health, but also their quality of life, home situation, work situation, relationship situation, and friend situation. This comprehensive assessment approach is essential because it allows for a holistic understanding of issues like cancer risk, screening behaviors, treatment adherence, and adjustment to survivorship. The case of Tara Hunter is a tragic story of how personal prejudice led directly to a preventable death when the EMTs refused aid and the hospital staff acted with negligence. Her story is so powerful in mobilizing a movement within the healthcare system that when I first came across her case, I couldn't help but wonder how different her faith would be if the framework of inclusivity and cultural humility was applied to the healthcare system back in 1995. Doing this project meant so much to me because I know as a nurse, I can advocate for my patients and make those changes that they need in order to get the quality care that they deserve. and needed, unlike Tyra's unfortunate fate. As nurses, we are often the first point of contact for patients, and we have a considerable influence on their healthcare experience. We have seen that the vast gap between discriminatory, competent care and inclusive, life affirming care is not impossible. It is a gap that can be bridged via education, by systemic changes, and by dedicated daily practice of cultural humility. We must ensure that every single patient, regardless of their identity, is met with dignity, with respect, and with competent, compassionate care that they deserve. Their lives are dependent on our capacity to care.